Hi, my name is Jeremy Teoh from the Chinese University of Hong Kong. I'm a urologist specializing in bladder cancer. Okay, so non-muscle invasive bladder cancer, technically it is a superficial disease, and I really believe a good quality surgical resection should be able to obtain a cure. But what we observe is that the recurrence rate of non-muscle invasive bladder cancer is far from satisfactory. On average, the one-year recurrence rate is around 30%, which is really, really high. And I think the way that we resect the bladder tumor is really suboptimal because there are two main problems with it. Firstly, when we resect the tumor in a piecemeal manner, there will be bladder tumor fragments floating around the bladder. The cells might reimplant to the mucosa, leading to disease recurrence. And secondly, as we resect the tumor in piecemeal manner, whether a complete resection has been achieved is really totally dependent on the surgeon's experience. Unfortunately, this is prone to error, and the tumor specimens are often fragmented, so it's hardly possible for a pathologist to really reveal the so-called resection margin. And therefore, en bloc resection has been proposed to overcome these problems by removing the bladder tumor in one piece. We minimize the tumor fragmentation. We also preserve the whole specimen and to ensure that a complete resection has been achieved by histological means. And therefore, this is a promising surgical technique that has raised a lot of interest in recent years. All right, so en bloc resection certainly has gained a lot of interest in recent years, but then there's a lack of standardization in this procedure. Hence, we feel that there's a need for a consensus statement to provide a standard of reference for urologists and healthcare professionals to follow when they practice this procedure. The consensus statement was developed in three main steps. The first step is really a systematic review to investigate the clinical effectiveness of en bloc resection when compared to conventional TURBT. And in this systematic review, we also identify the uncertainties around this procedure, and we try to group these uncertainties into 8 main domains, including the definitions and objectives of en bloc resection, case selection, surgical procedure, the different modalities of en bloc resection, the reporting of intraoperative findings, the specimen preparation and reporting of histological findings, post-operative management and follow-up schedule, as well as the data reporting and outcome measures. We then invite 200 urologists, pathologists, oncologists to complete a survey. And the survey is conducted in a 2-round manner, so-called a 2-round delphi survey. And after all, a total of 123 respondents answered the 2-round survey, and eventually 88 out of 103 statements were able to reach consensus after the 2-round survey. And then the third step is to have an expert consensus meeting consisting of 16 experts. Mostly will be urologists, but we also involve oncologists, pathologists, methodologists, as well as a patient representative. We try to go through those statements which has reached consensus, as well as those statements which didn't reach consensus. We try to discuss about them and revote again. And overall, at the end of the development process, 99 out of 103 statements were able to reach consensus after the expert consensus meeting. So we are really glad that more than 100 healthcare professionals actually contributed to the development of the consensus statement. And I think healthcare professionals agree on many aspects of the procedure, and certainly the results are something very representative of the view of the urology community as a whole. And the consensus statement certainly provides interim guidance for healthcare professionals to practice en bloc resection and to inform researchers regarding en bloc resection-related studies in the future. What our systematic review showed is that en bloc resection certainly has an excellent safety profile, but is en bloc resection really the way to go? Definitely we'll need a lot more high-quality studies to prove the value of en bloc resection over conventional standard resection before we can actually say that en bloc resection is the standard of care. I think there are two main things that we need to do. The first thing is that we really need high quality studies to look into clinically important outcomes, especially in terms of cancer control. For example, whether we can really reduce the risk of residual disease after resection, whether we can avoid second TURBT, and most importantly, whether en bloc resection can really reduce the recurrence rate of non-muscle invasive bladder cancer. And in Hong Kong, our center is leading a multi-center randomized control trial comparing between en bloc resection and conventional TURBT. We've recruited 334 patients. We aim for 350. So hopefully we'll be able to complete patient recruitment by the end of this year. And by the end of next year, hopefully we'll be able to report on the 1-year recurrence rate. And if we're really able to show that en bloc resection can reduce recurrence rate of non-muscle invasive bladder cancer, we have a very strong reason why we should switch from conventional TURBT to en bloc resection. But the second thing, which I think is equally important, is that even if we prove that en bloc resection is superior, we really need to ensure that this procedure can be properly disseminated to urologists worldwide. Therefore, surgical education and training is particularly important to ensure that the procedure can be done properly in a generalized manner. Conventional TURBT has long been criticized about the quality, and even en bloc resection, the same thing can happen. So really need to make a lot of effort to make sure that every en bloc resection is done in a very high quality manner.